Hi everyone. Thanks so much for having me today. I'm really excited to be talking about a condition that I'm very passionate about, and I really thank the organisers at Don't Forget the Bubbles for putting this condition on the map here. It's a condition that's been quite under-recognised, I think, historically, and so on behalf of myself, but even more importantly, the patients I treat with this condition, thank you all for being here and giving me your attention. This is a condition that has historically been very under-recognised and has often led to a delayed diagnosis, with the literature showing us that a lot of patients wait 12 to 18 months to get a clear diagnosis, often with several incorrect diagnoses along the way. And this obviously has a very big negative impact on patient experiences and patient outcomes. And it's really hard as a clinician to hear the harrowing stories that my patients tell me about how they came in through the ED, or they saw a general pediatrician, they saw this person, that person, they were told it was an infection, they got several courses of antibiotics, they were told it might be a malignancy, they had all sorts of other tests, and maybe they were left with almost nothing, and people saying, we don't know what's wrong with you, or nothing's wrong with you, or you just have to move on with your life. And that's particularly frustrating when CRMO is a condition that is treatable, and we have quite effective treatments to help these kids get back to their normal life, get back to playing sport, get back to going to school. But the light at the end of the tunnel for me is that there is some nice evidence that raising awareness about this condition improves time to diagnosis and improves outcomes for our patients. So there's a lovely paper from the UK a few years ago that showed that about 20 to 25% of patients with CRMO get referred to general pediatricians. Even more go through orthopedic surgeons, so if there's any of those in the audience, I really hope they're listening. And we know that a lot of them come through the ED at some point in their presentation as well. So in case you've wandered in here accidentally and you're not quite sure what this condition is, I'll explain some of the acronyms that we use. CRMO is chronic recurrent multifocal osteomyelitis. And more recently, we've started using the term CNO, just to be confusing and throw another acronym in there, chronic non-infectious osteitis. And that's in recognition of the fact that this condition is not always recurrent and it's not always multifocal. It's a condition that can affect one bone only and can continue to affect one bone only throughout the child's whole disease course. It is an auto-inflammatory bone disorder. So when I say auto-inflammatory, I'm differentiating it from autoimmune conditions because you get systemic inflammation without evidence of autoantibodies, antigen-specific T cells, or a specific pathogen that's triggering off that inflammatory process. It is a condition that historically in the literature was quoted as being 1 in a million. So who's going to spend a lot of time studying that when you've got 10 million other diagnoses as a general pediatrician you've got to be thinking of? But more recently, we've started to see that actually it's probably a lot more common than 1 in a million. I've worked in 5 tertiary pediatric rheumatology centres across the world, and the number of patients I've seen is certainly far exceeding that 1 in a million figure that's been quoted. There was a study in, I think, Germany a couple of years ago that in one particular institution, it was actually as common as bacterial osteomyelitis. I don't necessarily think that's completely true. That particular institution look for this condition a lot and they seem to find it, but I certainly think it's a lot more common than we're led to believe. If there's one slide I want people to pay attention to today, this is probably it. So when should you be thinking about chronic non-infectious osteitis? These kids will come to you either in your Gen Peds clinic, they might be admitted through ED, and they'll come with bony pain, which is often worse at night. And quite sensibly for a lot of us, that raises a bit of a red flag, and that's partly sometimes why they end up getting investigated. One of the challenging things, however, is that it's quite an insidious onset of a condition. So the parents won't come and say, Saturday he was fine, Sunday then his knee was sore, his leg was sore, or whatever. It tends to be quite a vague history, and I think that is part of the problem in the delay to diagnosis, that families possibly delay seeking medical attention, and then sometimes the history can seem a little bit nondescript and it's hard to know how to go about investigating it. This is a condition that you normally see in the sort of 7 to 12-year-old cohort. It's 2 to 1 female to male, like most conditions that I treat actually. And it's associated with a personal or a family history of psoriasis, palmoplantar pustulosis, inflammatory bowel disease, or enthesitis-related arthritis. I will caution you as well, patients don't come with all those labels attached to them, as we all know. I've certainly been the person who's found the psoriasis on more than one occasion by being the person who dig through the scalp and find those patches, or have a look at the weird rash that they've had for ages that nobody knows what it is. and that kind of pushes you down a little part of the diagnostic pathway. The clinical findings are notoriously subtle. This is a condition that can wax and wane over time. So if you see them in the ED, for example, with a flare, there might be quite a lot of swelling, potentially even some deformity or tenderness. But if you happen to see them in a Gen Peds clinic in between flares of disease, there can be very little to hang your hat on. Maybe some subtle asymmetry of the bones, for example, of the clavicles or something like that, but it's certainly one that can catch you out in how mild the clinical findings are compared to the reported pain. Because this is quite a rare condition, it's really hard, it's pretty much impossible to get any big data sets on it. So this slide I have, the picture on the left, is one of the larger cohorts of CRMO. It is 37 patients where they have looked at MRIs and tried to quantify which bones are most affected. And this is one of my top tips in trying to help work out whether this is a septic joint or whether it's CRMO. So the clavicle is very, very commonly affected in CRMO, and it's one of the kind of big giveaway sites because almost all other rheumatological conditions that I see don't affect the clavicle. Septic joint rarely affects the clavicle, same for bacterial osteomyelitis. So if you've got a kid, particularly in your ED, with a big clavicle swelling and you've done an x-ray and you know it's not a fracture, you know it's not a dislocation, I want you to think about this condition going forward. The other area I'll particularly highlight to you as being an area of concern is the vertebral bodies. So this condition can be a cause of back pain in the 7 to 12-year-old cohort. And if it's untreated and it's affecting the vertebral body, they can end up with fractures and they can end up with kyphosis. So just like in adult EDs where you have these little old ladies who get these wedge compression fractures, these kids can end up with very similar findings, and we actually treat them in a very similar way. We give them bisphosphonates, and that helps to stabilize it, helps to prevent fractures, and incredibly reduces their pain. There are a few other sites that you'll see this involved in, and classically the other main one is the metaphyses of long bones, and I'll show you some pictures of that in just a sec. So now you've got your thinking hat on, you've done a history, you've done an exam. How are you going to investigate? How are you going to call this one way or another as a septic joint or not? So the basic things like a CRP and an ESR, they'll probably be a little bit elevated. I'm saying a little bit, like maybe 20 to 50. If you've got a CRP of 120, 150, be thinking bacterial. It's probably not going to be CNO. If you see them at a first presentation, you do an x-ray, it might well be normal. So don't let that falsely reassure you too much. So on the x-rays, you can see on the top one of the clavicle there, I hope you can all see that that medial kind of part of the clavicle is really widened. It's quite sclerotic at the inferior margin. In the second x-ray, you've got the ankle, where the metaphyses of both the tib and fib, you've got some quite sclerotic change. And this condition loves to go for the metaphyses of long bones. Getting a definitive diagnosis often needs an MRI, which is hard, particularly in the acute care setting, to get an MRI. And even more, we often like to do a whole body MRI. So we as subspecialists, we're not asking for much, just a whole body MRI in the next 24 hours, thanks very much. And that's partly in terms of differentiating this condition from the other differentials you have in your mind. If you find 5 or 6 different sites all across their whole body MRI, you're going, well, this is not a septic joint. This is clearly something more systemic, more multifocal. And a bone biopsy is something else that we sometimes look at. So if you are thinking malignancy as a major part of your differential, it may be the only safe and sensible thing to do to actually get a piece of that tissue and say this is definitely not a bone tumor. As I've said before, this is an autoinflammatory condition. So all those fancy bloods that us rheumatologists sometimes ask for, ANA, ENA, double-stranded DNA, no help. Don't bother. Just don't do it. So I've alluded to already, obviously, the major differentials, and the two families here are bacterial infection or malignancy. So in terms of a septic joint, we've said that this is an autoinflammatory bone condition, which means that it doesn't necessarily affect the joints really at all. So if you've got mid-shaft or something like that, that kind of helps you in terms of ruling out your septic joint, but you can get adjacent arthritis to a particularly inflamed bone. Osteomyelitis is the other really big differential, particularly a subacute or a chronic osteomyelitis can present in a very, very similar fashion to this condition. In terms of malignancy, leukemia and lymphoma are the two most common that we think about, but we do also see neuroblastomas and primary bone tumors in the mix here. And among the rarer causes, I particularly highlight scurvy as being one that we've seen in increasing numbers in the last couple of years. So again, if you've got a kid who's got a history of autism or restricted eating or something, just thinking about that, because the MRI findings can be quite similar. These are some of my tips, and some of them I've kind of alluded to already as to how to differentiate these conditions. So if you've got symmetrical multifocal disease, that's really going to go against your septic arthritis type process. That's certainly going to be probably a CRMO, CNO picture. And again, being really conscious of, once you've got someone admitted at 2 a.m. and you've started them on antibiotics because you think it might be septic joint, trying not to anchor yourself to that first diagnosis and stick with it. If they're not responding to the antibiotics as you would expect, you've got to rethink. You've got to take a step back. You've got to go, hang on, is this really the right diagnosis? Is there something else I should be doing here? Particularly if they've got a history of inflammatory disorders, if they've got inflammatory bowel disease or something like that. And looking at exactly what bone or joint is being affected and the probability that this is going to be a septic joint based on that is quite helpful. Certainly fevers, abscesses, fistulas, sequestra, all those things much more likely in your infectious type processes. In general, kids with CNO, CRMO do not have systemic features. So if when you're examining them you find hepatosplenomegaly, you find a reactive lymphadenopathy or something, you're kind of going down a different path there. It's probably not going to be CRMO. So I hope I've given you a little bit of a picture of what you need to be thinking about when you see these sort of patients. I'd like to just kind of bring it home for you a little bit about what if we miss this condition. It's a condition that we've been told is rare. At one point people thought it was a 1 in a million condition. Is it really that important to add it to my ever expanding list of differential diagnoses when I see a kid with bone pain, because I see so many of them? So if you get the diagnosis wrong here, you might be sentencing your patient to treatments that are not going to help them. So prolonged courses of antibiotics, they might get side effects, they might end up having PICC lines or other interventions that are not going to benefit the patient. Even more importantly, you can be prolonging the patient's pain. This is a notoriously painful condition, and it's one in which complications like chronic pain type phenomena are certainly quite common. And those seem to correlate reasonably well with a delay to diagnosis. So it's really important to try and get this right to try and improve pain and overall outcomes for these kids. Like any bony condition that in the growing skeleton, if it's not treated adequately and early enough, you can contribute to deformity. So leg length discrepancies if they've got long bone disease, kyphosis if they've got vertebral body disease. And certainly last but not least, psychosocial impacts. Because this pain is often nocturnal, you get sleep disruption, and that has so many knock-on effects, as we all know, for children. But things like school attendance, participation in sport, health-related quality of life can all be quite significantly impacted. And it's just to bear in mind, again, that there are effective treatments available, and if you send these kids to us, we're very happy to try and get them on treatments to get them feeling better. So what should you do next time? How can you change your thinking when you are encountering one of these cases? The first thing is to have it in your mind. We all know that diagnoses that we've never heard of, we never make those diagnoses. So we just have to have it in the back of our mind. And particularly if this is a second or a subsequent presentation in a child who's been labeled as a septic joint, but the washout was no culture grown or anything, or if they're not responding to the antibiotics as you'd expect, they're still saying the pain is getting worse or their COP is rising or something like that. One of the simple things is that the first line therapy for this is regular NSAIDs. So it's not some crazy new MAB that the rheumatologists have just thought up. You give them a course of naproxen or some piroxicam, give them a month of that, and somewhere between 40 and 60% of them will go into remission. Both clinically and radiologically go into remission. So that's a fantastic, easy way to start the ball rolling for these patients. And the last thing is phone a friend. These are hard cases, and making these diagnoses can be really, really challenging. So at the start of these cases, you may well have an orthopod involved, an infectious diseases physician, rheumatologist, an oncologist. You might have a radiologist with a particular interest in musculoskeletal medicine. They're very, very valuable. They're my best friend in these cases. And it's always just worth having your team of your smart friends around you, helping you get all these patients improved and getting them down the right treatment path. I think I'll leave it there, but very happy to take questions or contact information there if anyone wants to get me offline. Thank you very much.
Thank you so much for framing that in a really, really helpful and functional way that I think when I receive a call next at 3 o'clock in the morning saying, I'm not sure about this one, what should I do? It's very, very helpful. One of the questions that I kind of had bubbling up was, we talked about, you mentioned that sometimes the patients who have gone to theatre and had a washout. Now, that's an operative procedure which is not small to organise, but also one of the possible investigations is a bone biopsy. How do you know if a patient needs a bone biopsy?
Yeah, so it's a really good question. I think it comes down to kind of the typicalness of the story. So we're developing some scoring systems. They're not been fully validated yet as to who really needs a biopsy. And it's based on a typical bone involvement, no red flags, so patient not having fevers, not having high CRP, not having weight loss, and a typical appearance on imaging as well. So sometimes we'll, for example, use an MRI to help us plan whether a bone biopsy is needed. And it's moving into that kind of an exciting phase of trying to work out who doesn't need a bone biopsy. Whereas, 10, 15 years ago, it was always, if in doubt, get a bone biopsy, make sure it's not a malignancy. Whereas a lot of these patients, we're pretty sure it's not a malignancy, but we're just trying to be certain. So it'll be really exciting to see how those scoring systems play out.
Thank you. And do you think, particularly with those patients who do have the recurring ones, that when they come to ED the second time, that's the question we can ask our orthopaedic colleagues, so that they only have one general anaesthetic?
Yeah, that'd be really nice to arrange. I've not been particularly successful at arranging that, to be perfectly honest, but I think in an ideal world, trying to minimise exposure to an anaesthetic would be great. Yeah.
I would like to live in an ideal world.
Yeah.
Do we have any other questions from the audience? We've got one just over here. Ben, could you give Sam the roving mics, please? Thanks.
Hi, thank you so much. In a child who's perhaps a little bit younger, metaphyseal involvement can also be a sign of non-accidental injury. How would you differentiate this condition in that context, I guess?
Yeah,
in a family
really,
that presents fairly often.
Yeah, very, very difficult case to imagine. So it's pretty unusual to see CRMO under the age of 7. There are a couple of very rare genetic subtypes that can present in younger children. And I suppose if you're thinking about those, a lot of those children will have more systemic manifestations. If it's more isolated bone involvement and you are concerned about like an NAI type situation, I think reviewing it with a radiologist is, potentially doing your full skeletal survey or your whole body MRI is going to be helpful there. That if you're seeing symmetrical and consistent involvement throughout, that might be more consistent with CNO. And if you see any other suggestive features of an injury, then that will point you that way a bit. Great question.
Do we have any other questions from the audience? Ben's running, which is a good sign.
Thank you for your talk. I guess this is something I agree I'd only sort of learnt about more recently, and it's been a bit in the front of our minds because we had a case that had been missed for a long time as well. And so I guess, in general peds, we often have this, my child gets recurrent nighttime leg pains that sound like growing pains, or recurrent other pains, and if you ask enough questions, they have pain in lots of different places. And so I guess I was just wondering, do you have any tips about, in our history taking, when should we seriously consider CRMO versus the kind of vague musculoskeletal pain that we commonly see in kids?
Yeah, absolutely. Growing pains are so hard because we were always taught nocturnal pain is a big red flag, but they're so common. I think when I'm doing a history of things like growing pains, it's very much the child that is really distressed during the night. Massage seems to help them an awful lot, Panadol, Nurofen not so much. And they're the kids that often jump out of bed in the morning completely fine and ready to go. So I think if they've got some lingering they're slow to get moving in the mornings and that sort of thing in a younger child, that would be a big red flag to me. And also if it seems to be favouring one side more so than the other. So growing pains classically are very, very symmetrical. If you're seeing a reactive stiffness in a knee or something in the morning, that would certainly go, this is not growing pains to me. I'd have a low enough threshold to refer them for a rheumatology opinion, to be perfectly honest. Very happy to see those kids.
Thanks, Grainne. Do we have any other questions? Probably got time for one more. Ben's looking static. All right, I've got one. what treatments are emerging for young people with the diagnosis of CRMO?
Yeah, so the first line for pretty much everybody would be non-steroidals, and the second and third line is basically trying to reduce pain, have normal bone growth. And there's two main areas that we look at. So one is the classic rheumatologist kind of methotrexate, immunosuppress them, adalimumab, that sort of pathway. And the other one, unusually, is bisphosphonates. So this is the only condition in which I prescribe bisphosphonates, and I often ask endocrine for their thoughts about it too. But bisphosphonates kind of inhibit, I suppose, your osteoclast activity. They have really potent anti-inflammatory effects. And we give IV bisphosphonates every 3 months to these kids, and the results are amazing. They improve so quickly, and they feel so much better afterwards, and the results tend to last quite a long time. One of the things to be aware of that is important for us is that actually you can get metaphysical changes after you've had bisphosphonates. So if you repeat their MRI, you go, hang on, that wasn't there before, and you've got to remember that they've had that treatment. So I think the decision on that depends on things like whether they have vertebral body involvement, which would certainly be high risk for me to start a bisphosphonate early, or if they have other rheumatological type conditions like IBD or enthesitis-related arthritis, I might go more down that kind of methotrexate immunosuppression pathway.
Thank you for sharing that incredibly sophisticated understanding of the condition that we're all learning very quickly about. Please join me in thanking Dr. Grainne Murray.